What are the most important skills a medical surgical nurse should have?
In my view, a medical surgical nurse requires a truly comprehensive and dynamic skill set to excel in such a diverse and demanding environment. At the core, exceptional clinical competence is paramount. This encompasses a robust understanding of pathophysiology across a wide range of medical conditions and surgical procedures, enabling precise patient assessment, accurate vital sign interpretation, and the ability to anticipate and respond to subtle changes in a patient's condition. Administering complex medications safely, managing various drains and lines, and performing meticulous wound care are daily necessities, all underpinned by strong critical thinking to prioritize interventions and make sound clinical judgments, often under pressure. Beyond the technical aspects, effective communication is equally vital. A medical surgical nurse must be adept at conveying complex medical information to patients and their families in an understandable and empathetic manner, ensuring they feel heard, informed, and involved in their care plan. This also extends to seamless interdisciplinary communication with doctors, therapists, and other nurses, fostering a collaborative environment essential for holistic patient outcomes. Building rapport and trust is fundamental, as is providing compassionate emotional support, particularly when patients are facing significant health challenges or difficult prognosis. Furthermore, superior organizational skills and adaptability are indispensable. Medical surgical units are fast-paced, with nurses often managing multiple patients with varying acuities and needs simultaneously. The ability to prioritize tasks efficiently, manage time effectively, and anticipate potential issues is crucial for maintaining patient safety and meeting care demands. Moreover, the capacity to remain calm and flexible in rapidly changing situations, such as a sudden patient deterioration or an unexpected admission, demonstrates resilience and professional composure, ensuring high-quality care is consistently delivered regardless of the circumstances. These combined attributes allow a medical surgical nurse to navigate the complexities of the role with confidence and precision.
Describe a time a patient's pain assessment didn't align with their physical presentation on the med-surg floor. How did you investigate and manage this discrepancy?
On one occasion, I cared for a patient on the medical surgical floor, Mr. David, a 65-year-old gentleman who was 2 days post-cholecystectomy. When I asked him to rate his pain, he firmly stated it was a 10 out of 10, which typically indicates excruciating, incapacitating pain. However, his physical presentation didn't quite align with this assessment. He was calmly watching television. His vital signs were stable and within normal limits, and he was able to shift position with minimal grimacing. This significant discrepancy prompted immediate investigation. My initial step was to delve deeper into his pain experience. I sat with him, asking open-ended questions like, "Can you describe what a 10 feels like for you right now? And what makes it a 10 instead of an 8? I gently inquired about his past experiences with pain and pain medication, noting any underlying anxiety or fear that might be amplifying his perception or expression. I also observed his nonverbal cues more closely, looking for subtle guarding or discomfort that I might have initially missed. A quick review of his chart showed no prior history of chronic pain, which helped rule out certain complex pain conditions. To manage this discrepancy, I first validated his reported pain, saying, "I understand that you're feeling an immense amount of pain, and I want to help you feel more comfortable." I then explained that while his body wasn't showing typical severe pain signs, his discomfort was still real to him. We discussed strategies. I offered repositioning, a warm compress, and guided breathing exercises first. I also clarified the pain scale with him, ensuring his understanding. After these non-pharmacological interventions, if he still reported a 10/10, I would then consult with the physician for further assessment, potentially exploring a lower dose of pain medication or an anxiolytic if anxiety seemed to be a significant factor, always prioritizing his comfort and safety. This approach ensured his pain was addressed while also maintaining a holistic view of his condition.
When assessing a postoperative patient, what are the 3 most critical findings you look for that would immediately trigger you to escalate care to the physician?
When assessing a post-operative patient, three critical findings would immediately trigger me to escalate care to the physician. Firstly, any sudden and significant deterioration in vital signs is a major red flag. This includes persistent hypotension, an unexpected and sustained tachycardia or bradycardia, a rapid increase in respiratory rate with associated difficulty, or a sudden, unexplained drop in oxygen saturation. Secondly, acute neurological changes demand immediate attention. This would involve any sudden alteration in the patient's level of consciousness, new onset disorientation, severe confusion not present before, or the development of new neurological deficits such as unilateral weakness or vision changes. Lastly, uncontrolled hemorrhage or signs of major fluid shift are paramount concerns. This presents as excessive and bright red bleeding from the surgical site, unexpected and rapid swelling, or systemic signs of hypovolemic shock like cold, clammy skin, pallor, and persistent low blood pressure despite fluid resuscitation. These findings suggest acute, potentially life-threatening complications requiring urgent medical intervention.
When administering a medication you've never given before on a busy medical surgical shift, what specific resources or steps do you rely on to ensure complete patient safety beyond just confirming the 5 rights?
When encountering a medication I've never administered before on a busy medical surgical shift, my immediate focus shifts to a multi-layered approach to ensure absolute patient safety, extending well beyond the standard 5 rights. My first crucial step is to access a reliable, up-to-date pharmacology reference, typically an electronic drug guide or the hospital's comprehensive formulary. I meticulously review key information, including its mechanism of action, precise indications for use, contraindications, and the full spectrum of potential side effects, distinguishing between common and severe reactions. Crucially, I focus on specific nursing considerations, what assessments are required before, during, and after administration, specific dilution instructions, safe infusion rates if it's informed medication, and any critical monitoring parameters like laboratory values or vital sign trends. Simultaneously, I always consult the patient's electronic medical record thoroughly to cross-reference the medication order with their current medical history, existing medications to identify potential interactions, and their latest lab results, which might influence drug metabolism or excretion. This detailed review helps me contextualize the medication within that specific patient's unique physiological profile. Beyond digital resources, consultation with experienced colleagues or the unit pharmacist is invaluable. A quick conversation with a peer who has experience with the drug can offer practical tips or highlight subtle nuances not always captured in a text. For high-alert medications, or anything particularly complex, directly speaking with the pharmacist provides an essential layer of verification and clarification on preparation, stability, and administration. Finally, I engage the patient in their care by providing clear education about the new medication, explaining its purpose, what effects to expect, and what potential side effects to immediately report. This not only empowers the patient, but also serves as an important safety net, as they often become the first alert system for adverse reactions. This comprehensive strategy ensures that even amidst a busy shift, patient safety remains my unwavering priority.
Tell me about the specific brand names of the most common 4 pumps, telemetry systems, or wound vac devices you routinely operated in your previous medical surgical setting. Describe a common troubleshooting issue you faced with one of them.
In my previous medical surgical setting, we routinely operated a range of essential equipment. For 4 pumps, the BD Alaris system was our primary workhorse, often complemented by Baxter Sigma Spectrum pumps, particularly for specialty infusions. Our telemetry monitoring was predominantly handled by Philips IntelliView systems, which provided continuous cardiac rhythm surveillance for our patients. For advanced wound care, the KCI VAC therapy units were the standard devices we utilized for negative pressure wound therapy. A common troubleshooting issue I frequently encountered, especially with the KCI VAC therapy units, were persistent leak alarms. This alarm indicates that the system is unable to maintain the prescribed negative pressure at the wound site, which compromises the effectiveness of the therapy. When this occurred, my immediate steps involved a systematic assessment of the entire dressing and tubing system. First, I would visually inspect the entire dressing, including the transparent film, for any visible tears, wrinkles, or areas where adhesion might be compromised, particularly around irregular contours of the body. I would then check the tubing connecting the dressing to the canister and the canister to the pump, ensuring there were no kinks, occlusions, or disconnections. Often, a minor wrinkle in the drape or a partially dislodged tubing connection was the culprit. If a leak was identified, I would meticulously reinforce the seal with additional transparent film, ensuring at least a 3 to 5 centimeters overlap around the edges of the original dressing. I would also confirm that the foam dressing underneath was adequately filling the wound bed and that the Synsat.RAC pad was correctly positioned without being compressed or kinked. If these basic troubleshooting steps didn't resolve the alarm, I would then consider changing the entire dressing, especially if the original one had been in place for several days or if the leak was significant and unidentifiable. This systematic approach usually resolved the leak and restored the therapeutic negative pressure.
Walk me through your detailed process for assessing and managing a patient admitted with fluid overload on your ward. What specific parameters do you prioritize monitoring?
When a patient is admitted with fluid overload on my ward, my approach is systematic and detail-oriented, prioritizing specific parameters to ensure comprehensive assessment and effective management. My initial assessment immediately focuses on their respiratory status. I'm looking for signs of dyspnea, orthopnea, or increased work of breathing, and I'll auscultate their lungs meticulously for crackles or rales, which signify pulmonary edema. Alongside this, I constantly monitor their oxygen saturation levels. Concurrently, I shift to their cardiovascular status. I assess heart rate and rhythm, check blood pressure for any trends, and critically evaluate for jugular venous distension, JVD, as an indicator of increased central venous pressure. I also examine for peripheral edema, noting its location, extent, and whether it's pitting. Strict intake and output, INO, measurements are then implemented immediately, and a daily weight is obtained at the same time each morning using the same scale, as this is the most reliable indicator of fluid status changes. Renal function is monitored through hourly urine output and trending blood urea nitrogen, BUN, and creatinine levels. My management strategy, informed by these assessments, begins with notifying the physician promptly to discuss findings and receive orders. I will then administer diuretics as prescribed, closely monitoring their effect on urine output and symptom resolution. Strict fluid restriction is a crucial component, requiring clear patient and family education on permissible fluid intake. I ensure the patient is positioned comfortably, typically with the head of the bed elevated, to ease respiratory effort. Skin integrity is also a concern with edema, so I implement meticulous skin care to prevent breakdown. Throughout this entire process, continuous, vigilant monitoring of all these prioritized parameters, meticulous documentation, and ongoing patient education about their condition and treatment plan are paramount. I collaborate closely with the medical team, ensuring a cohesive approach to effectively resolve the fluid overload and prevent complications.
How would you react to a significant drop in a patient's pulse oximetry reading?
If I observed a significant drop in a patient's pulse oximetry reading on my medical surgical ward, my reaction would be immediate and systematic, prioritizing patient safety above all else. My very first action is to assess the patient directly, not just the monitor. I would quickly check their level of consciousness, observe their respiratory effort for any signs of distress like increased work of breathing or accessory muscle use, and assess their skin color and capillary refill. Simultaneously, I would ensure their airway is patent and listen to their lung sounds for any abnormalities such as crackles, wheezes, or diminished breath sounds. While this rapid assessment is ongoing, I would also troubleshoot the equipment. I'd ensure the pulse oximeter probe is correctly placed, checking for common issues like patient movement poor perfusion to the extremity, e.g., cold fingers, or the presence of nail polish that could interfere with the reading. Often, simply repositioning the probe or moving it to a different digit can resolve a falsely low reading. If the reading persists, I try a different probe or even a different monitoring device to rule out equipment malfunction. Concurrently with my assessment and troubleshooting, I would initiate immediate interventions. I would elevate the head of the bed to a comfortable position to promote lung expansion and ease breathing. If the patient is on supplemental oxygen, I check the flow rate and ensure the oxygen delivery device is properly applied. If not, and the desaturation is significant, I would prepare to administer oxygen as per hospital protocol or a standing order, while simultaneously preparing to escalate care. I would immediately notify the physician with my complete assessment findings: the new SpO2 reading, the patient's respiratory rate, work of breathing, lung sounds, and any changes in their mental status. Depending on the severity and the patient's response, I would be prepared to activate the rapid response team, ensuring continuous monitoring and support for the patient until their condition stabilizes or further medical orders are received.
You've just received a handoff report, but during your initial patient assessment, you discover a new significant change in condition not mentioned. What is your immediate course of action and communication strategy?
Discovering a new, significant change in a patient's condition immediately after receiving handoff report requires a decisive and methodical approach, prioritizing patient safety above all else. My immediate course of action is to thoroughly assess the patient myself to verify the finding and determine its urgency. This means quickly performing a focused assessment related to the observed change. For instance, if it's a new neurological deficit, I'd conduct a rapid neurological exam. If it's acute pain, I'd assess its characteristics and the patient's current status. The goal is to gather objective data and understand the potential implications for the patient's immediate well-being. Concurrently with this assessment, my communication strategy begins. If the finding indicates an acute, potentially life-threatening situation, like sudden respiratory distress, new-onset altered mental status, or significant active bleeding, my first call is to the treating physician, using a concise SBAR, situation, background, assessment, recommendation, format to convey the critical information clearly and efficiently. I will describe the new change, the patient's baseline from the report, my current assessment findings, and suggest immediate interventions if appropriate. Once the physician is aware and initial interventions are underway to stabilize the patient, my next communication step is to address the discrepancy with the nurse who provided the handoff report. This conversation would be conducted professionally and privately, focusing on collaborative patient care rather than blame. I would calmly state, during my initial assessment of Mr. Peterson, I noted a new onset of facial drooping and slurred speech. I just wanted to touch base with you, as it wasn't something mentioned in report, and I've already notified the physician. The aim is to ensure continuity of care and to understand if the change developed very recently, was subtle, or if there was an oversight in the report. This approach fosters a culture of safety and shared responsibility, ensuring all team members are aware of critical patient status changes. Throughout, meticulous documentation of all findings, interventions, and communications is paramount.
If you noticed a consistent pattern of post-surgical patients at our hospital experiencing prolonged nausea and vomiting, how would you approach identifying the root cause and proposing a solution?
If I observed a consistent pattern of post-surgical patients experiencing prolonged nausea and vomiting on our ward, my immediate approach would be to treat this as a significant quality improvement issue, initiating a structured process to identify the root cause and propose sustainable solutions. Firstly, I would begin with a comprehensive data collection and analysis phase. This would involve reviewing patient charts to confirm the pattern across different surgical specialties, identifying specific anesthetic agents used, the types and doses of perioperative medications, especially opioids and antiemetics, patient demographics, age, gender, history of motion sickness or previous PONV, and the duration and severity of the nausea and vomiting. This detailed review would help to pinpoint commonalities and potential high-risk patient groups or procedures. Concurrently, I would initiate multidisciplinary collaboration. This is crucial for a systemic issue like this. I would engage directly with the anesthesia department to review their protocols for PONV prophylaxis and treatment, as well as the types of anesthesia utilized. Discussions with surgical teams would focus on specific surgical techniques or durations that might contribute. I would also involve the pharmacy for insights into medication availability and best practices, and the nursing team to discuss assessment consistency and current management strategies on the floor. Based on the gathered data and discussions, I would aim to identify key contributing factors. Hypotheses might include inadequate antiemetic prophylaxis protocols, an over-reliance on emetogenic opioid pain control, or a lack of standardized PONV risk assessment preoperatively. To propose solutions, I would advocate for evidence-based protocol revisions. This could involve implementing a standardized PONV risk assessment tool for all surgical patients, allowing for tailored, multimodal antiemetic regimens based on individual risk scores. We might explore optimizing pain management strategies to reduce opioid consumption where feasible, or incorporating non-pharmacological interventions consistently. Education for all relevant staff, nurses, anesthesiologists, and surgeons on these new protocols and the latest best practices for PONV prevention would be essential. Finally, I would propose a system for ongoing monitoring and evaluation to track the incidence and severity of PONV after implementation, ensuring the effectiveness of the new solutions and fostering continuous quality improvement.
Tell me about a specific instance where you identified a potential fall risk that was not immediately obvious, and what proactive interventions you implemented to prevent an incident.
One specific instance where I identified a subtle fall risk involved a 72-year-old patient, Mr. Henderson, on our medical surgical ward. He had been admitted for pneumonia and was making good progress, ambulating with a walker down the hallway earlier in my shift. However, during my late afternoon rounds, I observed him attempting to reach for his water glass on his bedside table, and instead of using his call bell or waiting for assistance, he leaned precariously far over the side of the bed. His usual, steady movements seemed slightly uncoordinated in that moment, and he grimaced subtly. Objectively, his pain score was still low, and his vital signs were stable, so on paper, he didn't fit the typical high-risk fall criteria at that precise moment. What struck me was the combination of his uncharacteristic reach, the slight unsteadiness, and the brief grimace, which suggested he might be experiencing new, low-level fatigue or weakness, possibly related to his ongoing recovery from pneumonia. Recognizing this as a potential change in his baseline mobility and judgment, I immediately intervened. I first repositioned his water, call bell, and other personal items within easy reach to eliminate the need for him to lean. Then, I initiated a more in-depth conversation with him, asking about his energy levels and if he felt any new dizziness or weakness, even mild. He admitted to feeling a bit more tired than usual. Based on this, I updated his fall risk assessment, increasing his score, and implemented a proactive toileting schedule to reduce his need to get up unassisted. I also placed a non-slip mat beside his bed and ensured his bed alarm was activated at a lower threshold. I communicated this change in his status and the new interventions to the oncoming nurse during handoff. Thankfully, no fall occurred, and he continued his recovery smoothly.
Describe a time you had to clarify an order with a physician that you believed was unsafe or unclear. How did you approach that conversation to ensure patient safety while maintaining a professional relationship?
I recall an instance with an elderly patient, Mr. Kane, admitted for pneumonia on my medical surgical ward. On the surface, he appeared calm and cooperative, able to answer basic questions during my initial assessment. However, I noticed a subtle, intermittent difficulty in his train of thought, a slight pause before answering, or repeating a question previously addressed, especially during the quieter evening hours. While not overt confusion, it was a deviation from the clear-minded baseline described in his admission notes and suggested a potential, but not immediately obvious, fluctuating cognitive impairment, a key precursor to falls. My immediate proactive intervention involved a deeper assessment of his cognitive status beyond routine orientation questions. I reviewed his medication list carefully for any new medications or recent changes that could cause sedation or confusion, such as certain analgesics or antibiotics. I also checked his recent laboratory results for electrolyte imbalances or signs of infection, both known contributors to altered mental status. Furthermore, I spoke with his family during visiting hours to understand his typical cognitive function at home and whether such fluctuations were common for him. This subtle information gathering confirmed my suspicion that he was at an increased, yet concealed, fall risk. To prevent an incident, I implemented several proactive measures immediately. I ensured his call bell was always within reach and educated him on its use. We initiated hourly rounding on him, where nursing staff would check on his needs, offer toileting assistance, and reorient him to time and place consistently. His bed alarm was activated to alert staff immediately if he attempted to get out of bed unassisted. We decluttered his immediate environment, ensuring clear pathways, and kept his personal items within easy reach. I also communicated my observations to the physician, leading to a review and adjustment of his evening medication regimen to minimize sedative effects. This comprehensive approach, based on early identification of a subtle cognitive change, effectively mitigated the fall risk and ensured Mr. Kane remained safe throughout his stay.
What is one common frustration you've personally experienced on a medical surgical ward, and what have you proactively done to try and mitigate or improve that situation for yourself or your team?
There was an instance recently where I received an order for Mr. John, a patient admitted with acute heart failure, that I felt required immediate clarification before administration. The order was for a continuous infusion of a potent intravenous vasodilator, typically a high-alert medication, simply stated as start 4 vasodilator at 5 milligrams per hour. Given the medication's narrow therapeutic index and significant potential for hypotension, the absence of parameters such as the concentration of the mixed infusion or a clear titration range and blood pressure targets made the order fundamentally unclear and potentially unsafe if misinterpreted. My immediate course of action was to thoroughly review Mr. John's current vital signs, especially his blood pressure and his fluid status, to ensure I had the most up-to-date patient information. I then quickly consulted our hospital's medication reference guide to refresh my knowledge on the drug's standard concentrations, usual starting doses, titration parameters, and the critical monitoring required, particularly regarding blood pressure. With this information in hand, I approached Dr. David, the prescribing physician, aiming to have a collaborative conversation focused solely on patient safety. I chose a quiet moment, away from the immediate bustle of the nursing station. I began by stating, "Dr. David, I'm calling about Mr. John and the continuous 4 vasodilator order. I just want to ensure I'm administering it exactly as intended for optimal safety." I then clearly articulated my concern. The order states start at 5 milligrams per hour, but I need clarification on the concentration of the infusion you prefer us to use, as it significantly impacts the volume infused per hour. Could you also clarify the target blood pressure range you'd like us to maintain and the titration parameters? Dr. David appreciated the clarification. He acknowledged the oversight in detailing the concentration and provided specific instructions for mixing the infusion, the target blood pressure range, and how to titrate the medication based on Mr. John's blood pressure response. He also verbally acknowledged the potential for hypotension and emphasized close monitoring. This approach allowed me to gain the necessary clarity to safely administer a powerful medication, ensuring Mr. John received the correct dose, while also reinforcing a professional relationship built on mutual respect and a shared commitment to patient well-being.
How often in your previous role did you actively seek out opportunities to mentor or assist a less experienced colleague with complex patient care tasks? Can you give an example?
In my previous role on a busy medical surgical ward, I actively sought out opportunities to mentor and assist less experienced colleagues whenever possible, seeing it as an integral part of fostering a strong, safe, and cohesive nursing team. It wasn't merely about responding when asked for help. Rather, I made it a point to observe new nurses or those encountering unfamiliar situations, offering my support before they felt overwhelmed. This often involved stepping in during complex patient admissions, managing rapidly deteriorating conditions, or navigating challenging interdisciplinary communication scenarios. I believe that sharing knowledge and practical experience is vital for both patient safety and the professional growth of our colleagues. A specific example that comes to mind involved a less experienced colleague, Sarah, who was relatively new to managing patients with complex cardiac conditions. We had a patient, Mr. Thomas, admitted with decompensated heart failure, requiring multiple titrated intravenous infusions, including potent inotropes and vasodilators, and his vital signs were fluctuating significantly. Sarah seemed visibly stressed, diligently trying to keep up with the titrations and hourly assessments. Recognizing her visible tension, I approached her calmly and offered to walk through Mr. Thomas's care plan together. I didn't take over his care, but rather I guided her. We reviewed each infusion's purpose and potential effects, discussed the physiological rationale for his fluctuating blood pressure, and together, we systematically assessed his response to each titration. I demonstrated my thought process for anticipating changes and prioritizing interventions, explaining the importance of vigilant monitoring of both the patient's clinical signs and the pump settings. I encourage her to articulate her concerns and uncertainties, creating a safe space for her to learn. By the end of the shift, Sarah felt much more confident in managing complex titrations and interpreting subtle patient cues. This collaborative approach not only ensured Mr. Thomas received excellent, safe care, but also significantly boosted Sarah's confidence and competence, strengthening her ability to independently manage similar situations in the future.
When educating a patient on new discharge medications, what specific strategies do you employ to confirm their understanding, particularly if there are language barriers or low health literacy?
When educating a patient on new discharge medications, particularly when faced with potential language barriers or low health literacy, my primary goal is not just to provide information, but to genuinely confirm their understanding, ensuring their safety and adherence at home. My comprehensive strategy begins long before the conversation itself. I first ensure I have all medication details clearly organized: the name, purpose, dosage, frequency, specific instructions like with food or at bedtime, potential common side effects, and important interactions. During the education session, I always employ a plain language approach, completely avoiding medical jargon and using simple, concise sentences. I break down information into small, manageable chunks, focusing on one medication at a time. The most critical strategy one utilizes is the teach-back method. Instead of simply asking, "Do you understand?" I empower the patient by saying, "To make sure I've explained this clearly, could you tell me in your own words how you'll take this medication? Or what will you do if you notice this side effect?" This allows me to immediately identify any misconceptions or gaps in their understanding and re-explain as needed. For patients with language barriers, I prioritize utilizing certified medical interpreters, whether in person, via video, or phone. This ensures accurate and nuanced communication, preventing misunderstandings that could lead to medication errors. If an interpreter isn't immediately available, and with a patient's consent, I might involve a trusted family member who is fluent in both languages, while still using simple terms and watching for nonverbal cues. Additionally, visual aids are invaluable. I use pre-printed medication sheets with clear icons, color code medication times, or even demonstrate how to use devices like inhalers or injectables. I ensure they have clear written instructions to take home, ideally in their preferred language if available. By combining these patient-centered techniques, I can effectively bridge communication gaps and confidently ensure the patient feels prepared and safe managing their medications post-discharge.
Describe a time you provided complex care to a patient who was highly anxious or demanding. How did you manage their emotional needs while still delivering essential physical care?
I vividly recall caring for Mrs. Eleanor, an elderly patient on my medical surgical ward who was highly anxious following a new diagnosis requiring immediate, complex surgical intervention. Her anxiety manifested as constant questioning, difficulty focusing, and frequent requests for reassurance, which, while understandable, made delivering her essential preoperative physical care quite challenging given the time constraints of a busy shift. My initial approach involved validating her feelings. I sat at her bedside, making eye contact, and acknowledged, "Mrs. Eleanor, I can see you're feeling very worried, and that's perfectly normal given everything that's happening." I then actively listened to her express her fears, primarily surrounding the uncertainty of the surgery and concerns about her family. This active listening helped establish a foundation of trust and allowed me to identify the specific sources of her distress. To manage her emotional needs while delivering essential physical care, I adopted a structured yet flexible strategy. Before performing any care task, whether it was administering medications, starting at 4, or assisting with hygiene, I would clearly explain each step in simple language, telling her exactly what I was going to do and why it was important. I offered choices whenever possible, giving her a sense of control. For instance, would you prefer to take your medication now or in 10 minutes? Or which arm would you like for your blood pressure reading? During more invasive procedures, I would guide her through deep breathing exercises or engage her in light conversation to distract her from the immediate discomfort. I also made a conscious effort to dedicate brief, focused moments to solely address her questions and fears, sometimes saying, "I need to finish this dressing change now, but I will be back in 5 minutes specifically to talk more about your concerns." I ensured her family was actively involved, encouraging them to provide comfort and reassurance as well. Recognizing the depth of her anxiety, I also communicated with a physician, which led to a low-dose anxiolytic being prescribed, helping to take the edge off her overwhelming worry. This integrated approach allowed me to safely and efficiently deliver the required physical care while consistently addressing her profound emotional needs, ultimately making her feel more secure and prepared for her surgery.
If you had to improve the post-surgery recovery rate at our hospital, how would you approach it?
If tasked with improving the post-surgery recovery rate at our hospital, my initial approach would be rooted in a comprehensive, data-driven assessment combined with strong interdisciplinary collaboration. I will begin by thoroughly analyzing existing recovery metrics, such as average length of stay for common procedures, readmission rates for post-surgical complications, and patient satisfaction scores related to the recovery experience. This initial data would help pinpoint specific areas where recovery might be slower or where complications are more prevalent. Alongside this, I would conduct a detailed process mapping of the entire surgical journey, from pre-admission education through intraoperative care, post-anesthesia recovery, ward management, and ultimately discharge and follow-up. Following this in-depth assessment, my next critical step would be to foster a truly collaborative environment by actively engaging all key stakeholders. This would involve formal discussions and working groups with surgeons, anesthesia ward nurses, physical therapists, dietitians, and pharmacists. Gathering insights from each department on perceived barriers to optimal recovery, whether they relate to pain management strategies, early mobilization protocols, nutritional support, or discharge planning, is essential. Simultaneously, I would research current best practices and evidence-based enhanced recovery after surgery ERAs protocols, tailoring them to our specific patient population and the types of surgeries most common in our facility. Based on this collective information, I would propose and champion the implementation of standardized, patient-centered ERAs protocols. This would likely include refining preoperative patient education to empower individuals in their recovery journey, optimizing multimodal pain management to minimize opioid use and facilitate early ambulation, ensuring robust nutritional support, and establishing clear criteria for early mobilization. Training and education for all staff will be crucial to ensure consistent adherence to new protocols. Finally, I would establish robust monitoring mechanisms with clear key performance indicators to continuously track the impact of these changes on recovery rates, allowing for ongoing adjustments and continuous improvement to ensure our patients achieve the best possible outcomes.
How do you stay informed about new developments in medical surgical nursing?
Staying informed about new developments in medical surgical nursing is something I consider absolutely essential, given the rapid advancements in healthcare. My approach is multifaceted and continuous, reflecting a commitment to evidence-based practice and lifelong learning. Firstly, I make it a priority to regularly read reputable professional nursing journals and publications. This includes peer-reviewed journals specifically focused on medical surgical nursing, which provide insights into new research findings, best practices, and innovative care strategies. I also follow publications from major nursing organizations, as these often highlight emerging trends and clinical guidelines. Secondly, I actively participate in continuing nursing education, CNE programs, and workshops. Many of these are now available online, which is incredibly convenient and allows me to access diverse topics and expert speakers, irrespective of geographical location. Our hospital also provides excellent in-service training sessions and grand rounds, which are invaluable for learning about new protocols, technologies, and patient populations pertinent to our specific setting. Beyond formal education, I find immense value in interdisciplinary collaboration and knowledge sharing in the ward. Daily interactions with physicians, pharmacists, physical therapists, and experienced colleagues during rounds or case discussions often bring new perspectives and highlight evolving treatment approaches. We frequently discuss challenging cases, which inherently leads to learning about the latest diagnostics or management techniques. Furthermore, I leverage reliable online medical resources and databases like UpToDate and PubMed to research specific conditions or interventions I encounter. This allows me to delve deeper into the evidence supporting various nursing interventions and to understand the rationale behind new medical treatments. This proactive engagement across various platforms ensures I remain current with the dynamic landscape of medical surgical nursing, enabling me to provide the highest standard of care to my patients.